if I have the privilege of inviting the last speaker, because she has been our student and now she is a mature professor of medicine and traveled all the way despite her family problems. Soma, would you please come on the stage? Her mother is not well, just out of the ICCU. Still, she took the early morning flight to be here on time and make her presentation. So that speaks, Agartala. So that speaks of her passion and love for this conference. Thank you, Soma. And so over to you for your presentation.
Thank you, Chairpersons. Good morning to you all. After 2.5 years of COVID-19 infection, we were in digital platform. So again, it's very nice to be here again. Okay, so I have prepared two cases. As I am a clinician, so I have keep the caption of clinical imaging correlation. So my first case, a 55-year-old Hindu female presented with gradual onset of progressive shortness of breath on exertion of NYHA class 2 to class 3 for last 5 years. She had palpitation off and on and easy fatigability. There were no comorbidities like hypertension, diabetes, or hypothyroidism. With this short history, on clinical examination, she had a pallor, JBP normal, and pulse 90 beats, regular normal volume and character, blood pressure of 130 by 70 millimeter of mercury. On her precordial examination, apical impulse at 6 intercostal space, 1 inch lateral to the midclavicular line, forceful, ill-sustained. S1 is soft, and there is a pan-systolic murmur of grade 3 radiating towards left axilla. No opening snap. There is a low-pitched mid-diastolic murmur of grade 2 at apex. So with these clinical presentation, we have a diagnosis of, provisional diagnosis of rheumatic heart disease with mitral stenosis and mitral regurgitation. And when we do the echocardiography, so this is the echocardiography showing there is no mitral valve is apparently normal, no doming, and there is a echo-dense, well circumscribed lesion in the left atrium plopping through the mitral valve. There was mitral regurgitation, probably of moderate grade. The four-chamber view showing that echogenic dense lesion with a stalk attached to the nearer to the fossa ovalis of the interatrial septum, and the echo-dense lesion plopping through the mitral valve. And there is a moderate grade of mitral regurgitation. So after doing echocardiography, when we correlate with our clinical findings, our final diagnosis was left atrial myxoma with mitral regurgitation. My second case, she is a 60-year-old lady presented with history of gradual onset of progressive shortness of breath on exertion for the last 1 year, which worsened after an episode of fever and cough for the last 7 days. There was history of recurrent onset of palpitation for the last 3 months, weight loss and pedal swelling of 1 month, and there was no significant past history or any comorbidities. With this short history, on clinical examination, the lady is thin-built. She had a pallor, bipedal pitting edema, and JBP was raised with prominent VY descent. Her pulse were was 100 beats, regular with high volume and blood pressure of 136 by 60 millimeter of mercury. On precordial examination, apical impulse at 6 intercostal space, lateral to the mid-clavicular line, forceful, ill-sustained. She had a palpable P2, there were left parasternal he were present, and as one was soft, there was loud P2, pansystolic murmur of grade 3 radiating towards left axilla, and pansystolic murmur of grade 2 at tricuspid area. There was the ejection systolic murmur at pulmonary area. So with these, we had a provisional diagnosis of, again, rheumatic heart disease, mitral regurgitation with patient in congestive heart failure. So when we do the echocardiography, this is the echo. She was a very thin-built lady. Her echo window was very poor. And there was the echogenic, echodense lesion in the left atrium, not well defined and not attached to the interatrial septum, like my earlier case. The lesion is around 1.6 by 2.2 centimeter, and she had a tricuspid regurgitation with estimated right ventricular pressure of 82 millimeter of mercury, and she had a moderate grade of MR with a vena contracta 0.5 centimeter with a VTI of 145.2 centimeter. So with these echocardiography finding, now we have a final diagnosis of mitral regurgitation with pulmonary arterial hypertension and left atrial thrombus. So my idea of presenting these two cases to evaluate the masses in the left atrium. So to summarize, my echogenic atrial mass may be cardiac tumor, may be thrombus, a definite stalk attached to the atrial wall and well-defined margin, and the echodense lesion moving with each cardiac cycle may differentiate a left atrial myxoma from a thromboid. Thank you so much.
What was the rhythm in the second case? Rhythm in the second case?
Yes, sir.
Rhythm. Was there atrial fibrillation?
A patient was in atrial fibrillation, and she had a dilated left atrium also, and in both cases there was echodense lesion in the left atrium. First one, after doing echocardiography, we come to a conclusion of left atrial myxoma, and second one with a thrombus in the left atrium.
Oh, thank you, Dr. Soma. Those were simple, but I think cases. But I think the kind of service you are providing in that region is enormous, is appreciable, laudable. My few suggestions.
Yes, sir.
Try actually in future, if we do an echocardiogram, record the ECG simultaneously. I mean,
Okay, sir.
because what is
Sir,
happening?
in our machine, we don't have that facility probably. It is there, but it is not provided in the hospital.
Yeah. No, I understand the difficulty.
Ask the application engineer
Yeah,
to get
yeah.
it at a,
Yes,
if you
sir.
make it a habit, it will become a habit.
Okay, sir.
Even the companies, when they are bargaining with the who are purchasing that, they usually do not give the ECG cable. Yes. They do not give. They do not
No,
give.
actually,
Unless you ask for.
Anurita, you are saying the right thing. Those who purchase the machine are not using the machine, and those who are using the machine are not purchasing the machine.
I am impressed. I never knew it. I just did not know it.
This is the experience. There are certain.
Yes, sir. G machine, yes, sir. One is G and another machine.
What I mean, G usually gives, but other than G, I'm telling you, there are a lot of vendors. They are not giving the ECG cable unless you ask for.
Sir, first one is Philips,
Yeah.
and second one is G machine.
So that's a real experience, sir. I'm telling you.
Why do you think the second patient has developed pulmonary hypertension? I mean, MR is not usually associated, chronic MR, not that kind of
Sir,
pulmonary hypertension.
yes,
Is it
sir.
the thrombus obstructing the mitral orifice, or, I mean...
No, it is not. It
was
is
not
not obstructing the mitral orifice. Actually, the lady was chronic smoker, and she had tricuspid regurgitation of sir with a gradient of 67 millimeter of mercury.
No, so-
and she had pulmonary venous, inferior vena cava collapse is also not there in inspiration.
Your second case most likely is patient of rheumatic heart disease, the mitral stenosis and mitral regurgitation both. That kind of pulmonary hypertension would not occur with pure MR. It is usually a mixed lesion. And thrombus also in pure MR, actually MR is supposed to be protective
Yes, sir.
despite atrial fibrillation.
Sir,
So we know that this is a mixed disease.
Yes, sir.
And patient has pericardial effusion also. Significant pericardial effusion, right ventricular dysfunction also, severe TR also. So it's probably a mixed mitral valve disease with the left atrial thrombus.
But sir, I couldn't find any mitral stenotic lesion in that lady. So I was thinking whether she had cor pulmonary like picture or not.
I don't know.
Sir, a CTPH is more likely in that setting. A chronic thromboembolic pulmonary arterial hypertension. 60-year lady, smoker, all these points are there.
With florid mitral valve disease, why would I think of...
Florid mitral valve disease, it's hardly a moderate mitral regurg.
No, but-
See, so let me first say one thing. If you can hear a pansystolic murmur, auscultation-wise, it is never mild or moderate. The only thing left is severe. I'll tell you from experience, in a 66-year female, you are able to auscultate MR murmur, it is always severe. So one of the concepts we had actually of that we just cannot, our ears are not tuned to hear mild or moderate MR.
No, whether it was a MR murmur or TR murmur that was also audible. That is,
It
has to
could
be
be a
differentiated.
TR murmur also.
But you said it
that
is radiating to axilla. You wrote it, it's radiating to
murmur was
axilla.
there, sir.
Radiating to
It
axilla
was
and other thing
radiating
you
towards
did
axilla.
mention. And P2 is loud, you wrote.
P2 loud,
So
sir.
my submission is that the MR probably we have not evaluated that adequately. Unless we want to bring another pathology for severe pulmonary artery hypertension.
So that is why, sir, I have presented the case because with MR and left atrial enlargement, she had such a thrombus in the left atrium. I couldn't find
So,
out.
madam, my feeling is that small things like X-ray and ECG come to great help actually. So sometimes these things should be done actually.
Sir, I have done the ECG, but because of lack of time, I have not presented. She had a RBBB on her ECG, and she had, sir, on X-ray, she has emphysematous changes.
Particularly in the rural
That
area.
is why I was thinking whether it is called
having-
pulmonary or
She's a
not.
smoker also.
He is a smoker.
Yeah.
We have seen that, sir, only because of this rural area smoker, pulmonary hypertension in the range of near about 50 to 60. So adding this with this, there could be severe pulmonary hypertension in
It is
this.
possible. But the way actually RV and RA are dilated, the pericardial effusion is present. The interesting part is pericardial effusion does not occur in corpuscularly, regardless of whatever is the PA
But
present.
sir, she had presented
is
with
also true.
cough and fever.
She has significant pericardial effusion.
No, she doesn't have.
No, you can see the pictures. Just again show
She
the
had.
picture.
Okay, sir, I missed it.
She has significant
She had presented actually with COVID-like symptom, cough and shortness of breath, fever. So she.
With COVID, you can inquire about DVT and pulmonary embolism with
Yes,
some degree of RV dilatation. Now
Pericardial effusion.
So these are beautiful cases from, I shouldn't say rural, you are from Agartala.
Yes, sir.
But a bit offbeat situation.
So we are not that much of
We should
developed.
congratulate you, and particularly two LMSs with two spectrum of diagnosis. Thank you very much for that. And
Thank you,
thank you for coming to Kolkata again. Wish your mother's recovery also.
Thank
So
you,
with
sir.
this, I think, Shobintro, you can end this.
So, we'll have Professor Anjanal Datta for the next session. We have just concluded the first session. So thank you, my co-chairs, and on behalf of them, I end the session here and call upon the next set of chairpersons and speakers.